So I think pancreatic cancer remains a challenging disease to treat from a medical oncologist's perspective. But we have seen, at least certainly over the past decade, incremental gains in survival for our patients as a consequence of new developments, particularly in terms of combination chemotherapy in the first-line setting. I think what offers hope for patients in 2017 is the fact that there's intense interest in understanding how we can better improve outcomes for patients with especially advanced pancreatic cancer, and a pretty focused interest in trying to understand the molecular taxonomy of pancreatic cancer, what are the drivers, and how to best individualize treatment for a given patient. The use of second-line oxaliplatin post-gemcitabine progression was established based on the findings of a phase 3 trial done in Germany called the CONCO-003 study. And that study demonstrated a survival benefit in patients who had prior gemcitabine monotherapy with a combination 5-FU oxaliplatin regimen called OFF. Our experience in Canada with a randomized trial in a similar patient population using the combination of a modified FOLFOX6 regimen wasn't able to demonstrate a similar benefit in survival. So I think the use of second-line oxaliplatin post-gemcitabine progression, there's conflicting data, but I think many people do still consider it an option for the treatment in these patients. The critical issue that's happened is that gemcitabine monotherapy is no longer the standard of care for patients in the first-line setting. And so a meaningful proportion of patients are getting oxaliplatin in the first-line setting through FOLFIRINOX. And gemcitabine, when used, is typically now used in combination with nab-paclitaxel. So it leaves us with the challenge of how do we interpret the data we've had in the past with gemcitabine monotherapy as the first-line backbone in the context of what we currently offer patients in the first-line setting. The second interesting thing that has kind of made the post-progression landscape more challenging is that we now have phase 3 data for a new agent called liposomal irinotecan in combination with 5-FU, which was demonstrated in the Napoli-1 study. And so that study also was predominantly gemcitabine monotherapy. So I think the good news is we have options. The challenge is trying to identify the best option for our patient with what we use as current first-line treatment for advanced pancreatic cancer. Current treatment guidelines, whether we're talking about ASCO guidelines, NCCN guidelines, ESMO guidelines, offer basically an algorithm of options for treaters when facing a patient with advanced pancreatic cancer. I think the limitation is that while they try to be evidence-based, much of the recommendations currently, because of the lack of maybe definitive evidence, especially in the post-progression setting, are consensus-based. And so when I look at guidelines now, I see a multitude of options, but no clear direction for clinicians as to how do you best select the most appropriate option for your patient. So when patients progress on first-line therapy, I think the key additional investigation that's required is understanding how best to identify and select patients. And that's based on clinical criteria, and more importantly, I think, is going to be based on molecular criteria. So we need additional investigations in terms of identifying biomarkers for patients to better understand who's going to predict who's going to respond to treatment. And so, for instance, if I have a patient who has progressed on gemcitabine nab-paclitaxel therapy and I identify a BRCA mutation suggesting platinum sensitivity, then my choice is going to be an oxaliplatin-based regimen post-progression. And that would be a much more rational approach to be able to offer post-progression therapy. So we need biomarkers, and we continue to need to push advances in the molecular understanding of pancreatic cancer.